Hi, Adult Health 2. This is Module 4, um, Coordinating Care for Patients with Renal Disorders. If you remember in Adult Health 1, we did renal disorders as well. So this just covers, this does have overlap, but there's some new stuff too. Sorry, we have a new dog and he's wild. This covers chapter 61, 62, 63. We do get to omit technically per the module, renal replacement therapy, which is dialysis. And we're going to talk about dialysis anyway, simply because when you're talking kidney failure, I don't know how you can't talk about dialysis. It's what we do for kidney failure. So, but we're also going to omit renal transplants, cancer, and trauma. Here's our objectives. This is just renal review, some vocabulary for you. This is slide number 4. Just go over your anatomy if you don't feel like it is fresh in your brain. Let's see, nothing too crazy there. So the renal disorders we're going to talk about are pyelonephritis, nephrolithosis, and urolithosis, kidney stones, right? Good old-fashioned kidney stones. Polycystic kidney disease and glomerulonephritis. We start with our urine assessment. Don't forget that, on top of color, odor, all of that lovely stuff, we're looking at pH, protein, glucose, ketones, even bilirubin. And then, do we have blood in there? Do we have RBCs, WBCs, casts? Erythrocyte casts are just pieces of RBCs. Okay, so like getting rid of like garbage, basically the spleen would have filtered out those erythrocyte casts and then we're flushing them out in the urine. And then, of course, bacteria, if we have anything growing. Remember that urine, technically speaking, should be sterile, right? We shouldn't have anything growing in urine. So assessment abnormalities, this is slide 7. This is just throwing a bunch of vocabulary at you. So remember, anuria means urine output of less than 100 mils in 24 hours. Dysuria, difficulty or pain. Hematuria is blood in the urine. Nocturia, frequent urination at night. This is different than enuresis, which is involuntary urination at night, which is that bedwetting, right? So enuresis is the bedwetting. You didn't mean to pee, but you peed. Nocturia is just you have to get up and go quite a bit at night. Oliguria is less than 400 mils in 24 hours. Polyuria is over 2 liters in 24 hours. Polyuria, over 2 liters in 24 hours. Retention, inability to fully empty the bladder, hesitancy, difficulty starting the flow. We talk about that a lot related to aging and BPH. And then incontinence, good old-fashioned incontinence, just means no control. So when we're talking about acute kidney injury, we have this pre-renal, intrarenal, and post-renal, okay? Pre-renal is external factors. So external factors that reduce renal blood flow. Intrarenal causes direct damage to the renal system, and then post-renal involves mechanical obstruction of the lower urinary tract. So acute kidney injury is defined as rapid and progressive azotemia. Azotemia is an accumulation of nitrogenous waste products such as urea, nitrogen, creatinine, and progressive increases in potassium. Okay, so we would be looking at those labs when we're diagnosing AKI. We would be looking at those labs to see where those levels are, to see if our person is in AKI. Pre-renal, most common cause, result of external factors. This can be like dehydration, right? External factors. It's outside of the body, causing something outside of the body is causing kidney problems. So dehydration is a good example. Here comes the dog. Intrarenal involves direct damage to the renal tissue, and it actually impairs the nephrons. Remember, the nephron is, the functional part of the kidneys. So this could be like contrast, nephrotoxic medications, right? Because we ingest those, and then they do cause physical damage to the kidney. Postrenal is our mechanical obstruction. So this could be like BPH or kidney stones. If if you remember with BPH, the prostate, is swelling and closing down and squashing the urethra. Okay, so that is causing an obstruction of the urinary tract. So make sure you're really comfortable identifying if something is pre-intra. Right, so AKI can progress through 4 phases. You do want to be familiar with these. Initiating is when the insult or injury first occurs. This can last hours to days. You're going to have high urine output, so that's going to affect all your electrolytes, sodium in particular. So decreased sodium concentration because we're getting rid of all this fluid. High specific gravity, right? We talked about all of that last semester related to fluids, and then hypo and hypervolemia. Same idea. That's what's happening. Oliguric phase is second in line. This is when that output drops below 400. So then we're going to see an increased sodium and electrolyte abnormalities. The body is no longer flushing everything that needs to be flushed. So you can get edema, cramping in the lower extremities, hypervolemia. We have decreased GFR. GFR is glomerular filtration rate, glomeruli filtration rate. And so decreased GFR means that the kidneys just aren't filtering everything they're supposed to be filtering. And this stage, oliguric, can last 14 days or longer. Okay, so 2 weeks or more. Then the diuretic phase occurs. This is when AKI has been corrected. All right, so now we've got the kidneys back to functioning. They're happy again. But the problem is now that they're functioning, you end up with dehydration because now the kidneys are just trying to release everything that's been built up. And we probably had you on a diuretic. And remember, a diuretic is used to help get all of that fluid out. So now that the kidneys are able to release all that fluid, they're just going to like go crazy and overboard, getting rid of everything. So during the diuretic phase, we really need to watch those electrolytes because they can fluctuate. So we need to be on top of that. Now, the recovery period is our last phase. That can last several months, all the way up to a year. So several months to a year. And the GFR returns to about 70 to 80% of normal. So that's good. Now I know my kidneys are functioning pretty well. So AKI risks is anything that causes decreased renal perfusion, right? So anything that causes the vascular system to constrict, okay? And then, so CV, diabetes, increased age related to decreased number of nephrons. So as you age, you literally have less nephrons. And don't forget the nephrons are the functional unit of the kidney, right? Sepsis can cause AKI, contrast, nephrotoxins, right? Anything that damages the kidney like that. And then we have perfusion problems. And then anything that's narrowing the vascular system. So our treatment is to eliminate the cause. So a lot of times, like if this is contrast or nephrotoxins, we're going to give you a bunch of fluids because, and then diuretics, because we want you to flush things out, right? We want you to be able to flush things out. We're going to try to prevent complications. That would include monitoring of those electrolytes to make sure that we don't add another problem to the mix, right? Then we're going to assist in recovery. You might be on HD, dialysis, hemodialysis. The good thing about AKI is like maybe we put you on dialysis for, weeks to, even a month or so while you go through those phases. And then usually once you hit that recovery period, you can come off dialysis. It's not like end-stage renal where you are now on dialysis for life. The med we're going to use for AKI, it's our diuretics, right? We're having trouble getting fluids out. We're going to help the body. We're going to use diuretics. Clinical manifestations. So lethargy, decreased urinary output. We're going to see an increased creatinine, decreased blood pressure, and decreased output. Okay. Lab values, obviously, we're going to watch our BUN and creatinine, electrolytes. We're going to worry about anemia and ABGs with this. Signs of overload. Remember hypervolemia, okay? Edema, maybe hypertension, maybe bounding pulse, neck distension, right? My jugulars are going to be sticking out. So all those signs and symptoms of hypervolemia. Assessments, um, anything that we're adding with renal, obviously vitals, but then we throw in urine output, daily weights. Remember, weight is the best indicator, non-invasive indicator of fluid status. I want to know what the peripheral vascular system is up to, right? Because that is going to affect that's going to tell me how much fluid I am holding on to or releasing. Do I have circulatory problems? That's going to affect my kidneys. And then oxygenation and breath sounds. If I remember with hypervolemia, it is possible for that fluid to back up into the lungs. So then I end up with a pneumonia situation. I may hear crackles. My O2 may be down because I can't breathe as well. Nursing interventions for AKI. Obviously, fluid balance. That makes sense. Position, ambulate, cough, and deep breathe. I don't want my person getting pneumonia because of backed up fluid. Monitor and document food intake. Remember, with our kidney people, we want to kind of limit protein. Protein's hard to process. Also, remember that meat protein to the body is the same as plant protein. It doesn't matter. So we don't want our people cutting out protein completely. That's not helpful to the body. That's not helpful to muscles, but they may be on limited protein. Also to take into consideration our sodium and potassium intake. If you remember, we talked about a lot about how salt substitutes actually have either hidden sources of salt, um, other chlorides, or they can have potassium in them. And both of those we worry about when the kidneys are not working at 100%. Also, if you recall, our different diuretics can affect potassium and salt. So we need to take into consideration what diuretic our person is on and how that is going to affect their output of sodium. Or remember, we have those potassium sparing diuretics that work with the RAS system. Okay. So what is the body doing with those? Education and evaluation for AKI, basically cause and treatment. We need to identify what caused the AKI, how to prevent it in the future, make sure our person understands that. again with the dietary concerns, and then monitoring that blood pressure, making sure it's staying within normal limits. Evaluation of outcomes. uh, Urine excretion is going to be back to normal, right? It's going to be back to normal. My labs are not going to indicate that I have any buildup of waste product. And then absence of any complaints. Simple. Here's a little slide that goes over pre, intra, and post glomerulonephritis. Glomerulonephritis. So this is inflammation of the glomeruli. So this is going to be intra because that is part of the kidneys. Blood loss due to trauma. Blood loss due to trauma. That is going to be pre, right? Ureteral cancer, intra, that's part of the kidneys. Dehydration. Dehydration is pre. Kidney stones, post. That is causing an obstruction. BPH, post-renal. That's causing an obstruction. Contrast that now results in AKI. That would be intra, because now we have damage, actual damage to the kidneys. All right, moving on to chronic kidney disease. The problem with chronic kidney disease is it's progressive and it can lead to irreversible loss of kidney function. Um, Risk factors for this, again, diabetes, recurrent UTIs, polycystic kidney disease, hyperlipidemia, hypertension, glomerulonephritis, malnutrition. So anything that is already causing damage to the kidneys, like polycystic kidney disease or glomerulonephritis, anything that is causing reduction in perfusion, and then, malnutrition. When we are malnourished, we have electrolyte imbalances, and that can cause damage to the kidneys as well. So the thing with chronic kidney disease is it goes slow, right? So it is characterized by a slow increase in BUN and creatinine. Um, it is a longer onset than AKI. And so the problem is, by the time it is identified, it has probably caused some significant damage. So that's part of the thing with chronic kidney, at least with AKI, we see those signs and symptoms pretty quick. We can identify it and we treat the problem right away before long-term damage really occurs. With chronic kidney, you don't really see it coming as quickly. So by the time our people are identified, we have real problems going on. And people can be asymptomatic for a while. And then, of course, don't forget that the most advanced stage of chronic kidney disease is end-stage renal disease. You'll see this written as ESRD, end-stage renal disease, and that is the most advanced stage of chronic kidney. Here is a nice little diagram of our clinical manifestations. Now, remember, when we have this progressive long-term damage to the kidneys, it's going to end up affecting every system in the body because sodium's off, fluid's off. We may have hypertension, likely have hypertension, which is going to affect the heart, the vessels. You can end up with pulmonary edema. Don't forget, if my potassium is off, lethal arrhythmias are my concern. Uh, if I have problems eliminating waste, you can end up with GI symptoms, right? You may feel nauseous, vomit. You may feel like, anorexia small a, just like not eating. And you can also end up with those neuro symptoms, headache, lethargy, fatigue, even confusion. Believe it or not, you can end up the whole seizure, coma, death thing. We talked about that related to sodiums. So, because of the buildup, remember the kidneys are getting rid of waste product, things that should not be building up in the body. So, if the kidneys aren't working and we have a buildup of toxins, that is going to negatively impact the body, right? I mean, that just makes sense. So once the patient has developed chronic kidney disease, um, we need to remove those waste products. This is going to be through dialysis. Dialysis takes those fluids out, filters them, puts the fluids back into the body. So it acts as the kidney. We call this renal replacement therapy, RRT. That's our dialysis. All right. We want to support the remaining function of the kidneys. So we're going to treat any clinical manifestations and try to prevent further complications. Um, so we're going to worry about like hyperkalemia, hypertension, anemia, dyslipidemia, um, anything like that, phosphate levels, right? Hypocalcemia, hyperparathyroidism. Remember, the parathyroid is in charge of our calcium. So we're going to worry about what's going on with that. We're going to be very cognizant of what meds and nutrition is happening. Renal transplant is the surgical option for end-stage renal disease. It's not really considered a cure, though. It will improve quality of life because hopefully your person's going to then be off dialysis, maybe not have as many dietary considerations. Um, but even if you get a kidney transplant, you have to be compliant with, all the recommendations for the rest of your life. And you're going to be on immunosuppressive therapy so that your body doesn't reject the organ. And that comes along with its own set of things because you're essentially in an autoimmune state or immunosuppressed state, I should say. So you have to make sure that you avoid crowds. You'd want to be careful during flu season, all those things that we have talked about. Um, Basically, with chronic kidney disease and RRT, for the most part, dialysis is run 3 to 5 days a week, and it lasts about 4 hours of treatment. So people can go to outpatient clinics to get their dialysis, but that's still a big commitment. That's basically a part-time job, right? 3 to 5 days a week, about 4 hours at a time. So as you may guess, compliance is definitely a problem. And then if your person wants to go on vacation, be out of town, they're going to have to find someplace where they can go to get their dialysis done, right? Because if they skip dialysis, you have this crazy buildup of toxins, and that's when people go septic and end up back in the hospital. Okay, electrolytes go crazy, you end up with arrhythmias, all that stuff. So people should not skip dialysis. They do anyway, but that is our biggest concern is compliance. Um, some patients may have AV fistulas in place. If they have a fistula or a graft in place, we do not do blood draws on that arm. We do not take BPs on that arm. So if we get a patient that has end-stage renal, even if we're not treating them for an end-stage renal concern, we still need to know whether or not they have a fistula because it's going to affect how we care for them. And then if our person is on dialysis in the hospital, if I am taking fluids out of your body and flushing them and putting them back in, if I give you your meds right before dialysis, they're all going to get flushed out of your body, okay? Especially your water solubles. So we need to take into consideration our patient's dialysis schedule as to when we are administering or holding medications, because we may want to administer meds after dialysis. Also, if our person is on any cardiac or, hypertension meds, we may hold those before dialysis also, because people can go hypotensive during dialysis. We're pulling that fluid out. Yeah, we're putting it back in, but sometimes the body can overreact and go hypotensive. So we don't want to give like hypertensive meds that may exacerbate that risk, right? I know when we had patients on dialysis, we would just run some albumin for them. Albumin is a volume expander, so that just kind of pumps up the volume and helps either really quickly resolve that hypotensive situation, or if a patient has a history of going hypotensive during dialysis, the dialysis nurses would just run albumin like right off the bat to just avoid that situation altogether. This slide 20, this just kind of gives you a nice little diagram of dialysis. The thing to know with dialysis is complications can occur during or after. Hypotension, we just talked about. Your person also could feel kind of lightheaded, nauseous, vomiting, seizures. They may have vision changes. They could have chest pain related to cardiac ischemia. So what we would do in those cases, if you happen to be running dialysis, is to slow down the rate of the fluid exchange. When you have an unstable patient, we do continuous uh, RRT, CRRT, so continuous dialysis. And the benefit of that is the rate of fluid exchange is slower. So the body is basically not as traumatized by the fluid exchange. Okay, it just goes super slow. Your person may also have muscle cramps and then be tired afterwards. Pretty much if we had a patient who had dialysis in the morning, they were not going to work with PT in the afternoon. They would pretty much watch TV and or sleep the rest of the afternoon. So now, granted, those were critically ill patients, so they're already very depleted. But dialysis is kind of exhausting for people. The body gets tired. We do worry about bleeding because there can be altered platelet function related to uremia. And we do use heparin during dialysis, so that could affect that out as well. Now, if my person has a port, if they have a fistula, whatever, I still do worry about potential for systemic infection. Patients on chronic dialysis, they just have a higher risk of developing Hep B, Hep C, cytomegalovirus, CMV. CMV we really only see in the chronically ill, and then HIV. So our bloodborne pathogens sort of things. Multiple blood transfusions, immune system depression, and underlying disease processes all contribute to that risk of infection. A really weirdo thing is dialysis-associated dementia. This is a progressive, potentially incurable neurological complication associated with long-term dialysis. It's thought to be due to aluminum, which is present in the phosphate binders in the dialysate. The dialysate is one of the fluids they use when they run HD. Um, so and a long-term consideration for Alzheimer's has been aluminum buildup, right? That's why some people will use deodorants that don't have aluminum compounds in them. That is related to findings that kind of show that buildup of aluminum can be related to neurodysfunction. Uh, Dialysis disequilibrium syndrome results as a result of very rapid changes in the composition of the fluid. We really talked about that. So there's lots of pre and post things to take into consideration. And to run dialysis, you do have to be specially trained. It's not something that just as a floor nurse, you're going to be running HD. You're going to be certified in dialysis. Um, this is just another slide with our HD complications. Let's see. This is about CRRT. That's that continuous renal replacement. This is going to be a one-to-one situation. Your person is unstable. If they need to be on CRRT, they are unstable. We are worried about this person. So same process as dialysis, just goes very slow. A lot of monitoring of vitals, patient condition, that sort of thing. Last but not least is peritoneal dialysis. This is super weird. The benefit of peritoneal dialysis is that people can do it at home and it doesn't require a dialysis machine. You have some drainage bags and then a sterile bag to drain into. You put the dialysate, which is the fluid, into the peritoneal cavity, through an indwelling catheter. The dialysate kind of stays in that peritoneal cavity for a specific length of time or dwell time, and then you just gravity drain it out into a sterile bag. So the benefit of this is you can pack these bags to go on vacation with you. If you want to go into the woods for 2 weeks, live off grid, you can take your peritoneal dialysis bags with you. So that is the benefit of this. It's just kind of weird, right? I've only experienced one patient ever that actually used peritoneal dialysis, and we all had to YouTube it to make sure that we were up to date on how this actually works. So really our consideration with peritoneal dialysis is to monitor that abdominal girth because we want to make sure that they are not retaining any fluid. So CKD assessments, chronic kidney disease assessments, not really any different than AKI. I's and O's, weights, labs. We are going to worry about pulmonary, cardiac, and peripheral vascular, okay? And then if our person has a transplant, then we have all those considerations related to transplants. So CKD patient education, again, don't skip dialysis. Don't do it. We're going to be monitoring all those labs. Again, they need a low protein, low sodium, low potassium diet. Salt substitutes are not okay. Probably they're going to be on fluid restrictions also. We don't want to overwhelm the kidneys. If our person, normally for a healthy person, we like that whole 2 to 3 liters a day of fluid. We are going to limit that for our CKD person because we don't want that fluid backing up. We already know that those kidneys can't handle processing all that fluid. So we don't want that fluid turning into edema, turning into pulmonary edema, backing up in the body and causing more problems. That's pretty much it for that. All right, pyelonephritis. This is where your good old-fashioned UTI travels up the urethra to the kidneys, okay? So we end up with inflammation of the kidneys. It can affect the bladder. Females are at greatest risk, just like UTIs, all the normal risk factors. Multiple or untreated UTIs are a risk for pyelo. Sexual activity for women can be a risk for pyelo because that bacteria can be pushed into the urinary tract. Foleys are a risk for a pyelo. The longer you have a Foley in, the greater your risk for UTI, and therefore the greater your risk for pyelo. Diabetes, obstruction, pregnancy. If you do not complete your full antibiotic course related to a UTI, this puts you at a greater risk for pyelo. And then urinary stasis. Clinical manifestations. This is an infection. So you're going to see all the infection things, fever, and then it's very much like a UTI. So nausea, vomiting, that flank pain. Our kidneys can actually get enlarged. So we may be able to see that on an MRI. Frequent urinating, just like UTI, hematuria, dysuria. I do worry about septic shock if my UTI has managed to travel to my kidneys. I worry about septic shock. what you're going to see is a significant drop in blood pressure. Okay, your blood pressure is just going to dump on you. Likely septicemia, meaning I'm going to have a matching organism in the blood that I have in the urine. So we would do a UA with culture and sensitivity, identify your bacteria. If you have septicemia, that means that same organism has now spread to the blood. And this is going to lead to systemic inflammation. So diagnostics for pyelo. Our X-ray that we do is called a kidney ureter bladder, so KUB. All right, KUB. Our CT for soft tissue stuff, and also that can show hydronephrosis. I think I said MRI earlier. Sorry about that. Should be CT. I apologize. Treatment. Our person, we may put them in the hospital for IV antibiotics. Okay. That's how serious this is because we don't want that infection turning into sepsis. Mild cases could be treated outpatient. I also want to flush my kidneys. So this is not kidney dysfunction. This is not just an infection because it's bad, but at least my kidneys are still functioning like kidneys. So I can do my 2 to 3 liters of fluid a day. I can do that. And in doing that, I'm trying to flush out that bacteria, right? I want to clear the system of that bacteria. Complications, scarring of the kidneys, permanent damage, right? We talked about sepsis. And pyelo, if untreated, can lead to chronic kidney disease because of that permanent damage. So patient education, complete all those antibiotics, right? And then hydrate, hydrate, hydrate. 8 glasses of water a day, which basically comes out to 2 to 3 liters. Our person may be on pain meds, so pain meds as prescribed. Empty bladder completely when urinating. That's that risk of urinary stasis. And then reporting any new signs or symptoms of infection, like fever, chills, also hematuria, increased new back pain. We worry about this becoming more serious. And then we're going to do education about how to avoid UTIs, right? Because pyelo starts as a UTI. So if we can avoid UTIs, we are going to be able to avoid pyelo. Problem solved. All right, kidney stones. We did talk about kidney stones in Adult Health 1. I don't know if anybody remembers the pictures of the kidney stones, but how spiked they are, right? Those sharp spiked edges. So they are very painful for people. A lot of times, most of the time, they are related to calcium buildup. They are commonly related to dehydration. And so we're going to be wanting to be monitoring for our signs and symptoms of dehydration. And then that obviously is going to be an education point for our patient who has kidney stones. Remember with dehydration, thirst, fatigue, dizziness, dark urine, strong odor, dry mouth, pallor, right? No color, cool, clammy skin. Um, Remember our low urine output. Um, uh, oh, I can't think of the word. I'm losing my mind here. Um, but to figure out low urine output, it's 0.5 milligrams per kilogram per hour. Okay, that is our specific, can't even think, 0.5 milligrams per kilogram per hour. I keep wanting to say treatment. That is not the correct word. But 0.5 milligrams per kilogram per hour is very specific. If we know how much our patient weighs, we can figure out what their ideal output should be. And then in general, we can use 30 mils per hour as a norm. And that is our more general thing that we can use. Formula Formula is the word. Hooray, the brain kicked in. That's great. So output less than this could indicate that they are headed for AKI. That would be my concern. And also remember, with stones, I worry about obstruction. So you can end up with urinary stasis, and all of that sort of stuff, which then puts you at risk for UTI, pyelo, blah, 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 all the things we just talked about. Kidney stone risk factors. This is our males for this one. Males are at greater risk. Caucasian, family history. If you have damaged lining of the urinary tract, this puts you at greater risk. Things, if that lining, lining in the body is usually nice and smooth so that things can flow and pass through and not get stuck. But if you have damage to any of this lining, that's when we see clots and stones and all those sorts of things that can cause obstruction, because you now have basically like little pockets where things can get stuck and accumulate, right? So things that would normally flush out nice and smooth are getting stuck, they're starting to accumulate, so we can end up with clots, stones, anything like that. So damaged lining of the urinary tract would be a risk factor. Decreased urine flow, concentration of urine. This is our BPH people, older people. Urinary stasis, dehydration, also our older people. And then anything that results in high alkalinity or acidity can go either way, ends up, anytime something like that is off, whether, we have acidosis or alkalosis, you can end up with accumulation because the body's not working right. So signs and symptoms of kidney stones: people may get bloody urine, hematuria, painful urination, dysuria, oliguria, or anuria if there's an obstruction. We get this flank pain again with the kidneys, pallor, nausea, vomiting, diaphoresis. Kidney stones, the pain related to kidney stones, I have heard it compared comparably to childbirth. I don't know if that's true or not. I've never had a kidney stone. But just for somebody to make that leap, it must be pretty severe pain. So diaphoresis, crazy amount of pain, that makes sense. Here is just a picture of different types of kidney stones. We have the calcium oxalate is on there, uric acid. Remember, we saw the picture of uric acid stones related to gout. Remember that? Those were super spiky as well. That would be very painful. So that's just kind of a cool little slide with all those pictures. Diagnosis: we're going to do a non-contrast CT. We're going to do our KUB again. That's the kidney, ureter, bladder x-ray. And then we might, on children or ladies who are pregnant, use an ultrasound simply because there's no radiation exposure. Our treatment. So our treatment for kidney stones, really, we are hoping that people just manage to pass the stone on their own. We call this trial passage. About 50% will just pass spontaneously. We do send our people home with a little strainer to strain their urine so we can definitively identify when that stone passes. We're also going to treat them for pain control, so that's symptom management. And then we may use an alpha adrenergic blocker, which relaxes the ureters so the stone is easier to pass. If you remember, we use alpha adrenergic blockers with BPH, right, to help people pee, help men pee easier. Okay, same idea here. And then we want people to hydrate. The better, this is not kidney dysfunction again. So we can have them do those 2 to 3 liters. And we want them to do those 2 to 3 liters because the more you're hydrating and flushing, the better the opportunity for that stone to flush on out. Now, if the stone is too big and is not going to flush on its own. We do have surgical management. There's ureteroscopy, percutaneous nephrolithotomy, and corporeal something shockwave lithotripsy. That one's kind of cool because they actually use sound waves, like shock waves, and just blow up the stone. And then you pass those teeny tiny little pieces. So nursing interventions, obviously meds as ordered. We're going to maintain that fluid status. We're going to help strain urine, identify some stones. It'll be great. Possibly insert a Foley catheter, especially if our person is having trouble with retention related to the stone. We don't want urinary stasis to occur, so a Foley might possibly be an answer to that. Patient education is all about straining that urine. There's a lovely picture right there. You know, this person does not have gloves on in this picture. And even though it's their urine, I would highly recommend gloves, but that's just me. They may want to call their provider for increased fever, chills, nausea, vomiting, or uncontrolled pain. This can indicate infection, right? We're worried that that stone could be causing obstruction or other problems and result in infection. And then we are going to educate them about kidney stone prevention, which basically comes down to maintaining that fluid status. You know, don't let yourself be dehydrated. All right. Polycystic kidney disease. This is a genetic disorder, all right? Genetic disorder for polycystic kidney disease. The problem is you end up with these fluid-filled cysts in the renal tubules. So autosomal dominant is the most common, and this does not hit people till they're like 30, age 30. And then we have autosomal recessive, and this means that at birth, these cysts are present. Okay, so these poor little babies. The problem with a cyst, you know, it's fluid filled, right? So it can become big and compress the surrounding tissue. And in compressing that surrounding tissue, it can destroy the underlying renal tissue. So the compression of the underlying tissue reduces the blood flow and the nutrient supply. And so that can cause the kidneys to shut down, right? That's a problem. So controlling blood pressure is really our number one nursing intervention with this. A lot of times when the cysts are small, there's not going to be any clinical manifestations. You know, they're just kind of existing. They're not really doing anything yet. So really, before we have signs and symptoms hit, those cysts have to get large enough that they are causing problems. So we're going to see at that point all the usual kidney things. Hypertension is probably the biggest one, but hematuria, that flank pain, low back pain, maybe some headaches, and you can get abdominal pain with this as well. Physical exam, those the kidneys may be bilaterally enlarged. Okay, so we're going to see this reflected in increased abdominal girth. This disease can progress to end-stage renal disease in about 50% of patients by the age of 60. So basically, let's say, you know, that one that hits you at 30 years old is the most common. So you're living with this for essentially 30 years. And then at that point, you have a 50-50 chance of it having progressed to end-stage renal, which means then you are going to be living your life on a dialysis schedule, right? That 3 to 5 days a week, 4 hours a pop. Okay, so this is a hard diagnosis for people because it does not have a very positive outcome with it. So common complications, severe and lifelong, long-term hypertension. So this is going to be hypertension that we can't fix with meds. It's not going to go down. So if we can't fix that hypertension with meds, that is putting your vascular system, your heart, everything at continued increased risk for damage because the body is not made to live in a hypertensive state. It damages everything. So if I can't control your blood pressure, that is going to put you at risk for other chronic disease processes. Polycystic kidney disease also puts you at risk for renal calculi, so stones, recurrent UTIs, hematuria, and then heart valve abnormalities. We also worry about aneurysms with these guys. And one of the weirdo things is you can develop cysts in the liver and or the GI tract. So these cysts may go outside of the kidney. So the cysts that form in the liver destroy liver tissue, and then that impairs normal functioning of the liver. And the liver is one more thing that helps us get rid of those waste products, and helps in digestion and all of that. Remember all of that? So the cysts destroy the liver, and we are now at even greater risk of retaining toxins because now we have one more filter not working. Okay. Um, you can also get cysts in the intestines, so that can cause diverticulosis. Remember, diverticulosis is like the outpouching of the intestines, and then you can end up with diverticulitis, which is when those outpouchings become infected. Most common complication of PKD is going to be renal failure, by far, but we can't underestimate how severe the other consequences of it affecting other systems can be. It's because it can very severe. Labs and diagnostics for PKD, urinalysis, CMP, which is a complete metabolic panel, and then we're going to do MRI, CT, ultrasound, IV pyelogram. So our assessments, same old, weights, I's and O's. Now, don't forget about that blood pressure, right? And then oxygenation, because we can end up with anemia related to this. And then, of course, our electrolytes, in particular, as usual, sodium and potassium. The diet modifications, same old, low sodium, low potassium, follow your protein recommendations and decrease the phosphorus. Don't forget that phosphorus. Remember, we see that most related to like diet sodas and stuff. So, your people might think that they're doing themselves a favor by drinking a low calorie soda, but that phosphorus can be damaging. This person could be on fluid restrictions because we do have kidney damage related to this. We're going to monitor for UTIs, electrolytes, fluid imbalance, and blood pressure. That's our patient education. This is slide 46 is patient education, but same thing we just talked about, right? All right, glomerulonephritis. Glomeruli oversee filtration. So they are very much the functional unit of the kidney, okay, the glomeruli. So glomerulonephritis, holy cow, glomerulonephritis right? Is inflammation of the glomeruli. And this can lead to end-stage renal disease. It is one of the leading causes of ESRD. Acute glomerulonephritis is often related to infection. Strep likes to do crazy things, and glomerulonephritis is often related to a strep infection. Chronic glomerulonephritis is going to develop over 20 to 30 years. So this is another instance where the damage is occurring slowly. And so those signs and symptoms may not pop up until we have real severe damage, possibly having progressed to that end-stage renal disease. And then again, that is dialysis life for you. So here's our risk factors. Again, strep. Strep likes to do all sorts of weird things. And then immune diseases like lupus or good pastures, vasculitis, itis, inflammation of the vascular system, hypertension, diabetes. Again, those things that are causing constriction of the vascular system. Anything that reduces blood flow to the kidneys is not good. Our signs and symptoms, we're going to have protein in the urine, hematuria, erythrocyte casts. Those are those pieces and parts of broken up red blood cells, maybe WBCs in the urine, edema because we're having a backup of fluid. If the glomeruli are in charge of filtration and they're inflamed and unable to filter, of course we're going to have edema. We're having backup of fluid. Decreased urine output, right? Hypertension. I have too much fluid, so hypertension. And then my labs are all going to be off. Assessments, same old, same old. Vitals, weights, eyes and nose, abdominal girth, dietary, lab analysis. Complications is that this can lead to acute kidney injury. It can lead to chronic kidney disease, and hypertension is a big problem related to this. So our education, we want people to understand the disease process. We want them to be compliant and understand their meds. We're going to need them to monitor their blood pressure pretty regularly because we know that fluid buildup is a problem, which can cause BP. Dietary restrictions, here we go again with the protein, sodium, potassium, and then, just avoid infections. We don't want to add that problem on top of everything else. And that's just good life advice anyway, right? So that concludes our renal presentation, and that was less than an hour. So you're welcome.